this session, and we call Dr. Edwin to present ratio of pacemaker in the third world, medical, legal, cultural, and ethical perspective.
Thank you very much. Good morning. And Prof has given us a lot of food for thought, and he's giving me a good context within which I want us to look at the case on hand. Reuse of pacemakers in the developing world. My co-author and I, this is a project that is in the womb, but it's basically work that was done as part of our doctorate in Loyola University. So that's how come you see Loyola Bioethics there. For some time now, at least, if you look at the literature, reuse of pacemakers is not something that's just been thought about. Several countries, and namely Sweden, which was the first, as early as the 70s, they were explanting and reusing pacemakers in some of their population. India, Canada, they've previously explanted and re-sterilized pacemakers from deceased donors for reutilization. But some of them stopped because of certain issues. They were wondering, is this ethical? And is this right? Is this just? Can we do this legally? So in a situation where a lot of people in Africa can't even access this, can we be dispassionate and look at our options? So my question to this audience is this option applicable in the African context, where pacemakers are beyond the reach of most patients who need them? For the average Ghanaian, you can't afford a pacemaker. I'm a doctor. My husband is a doctor. If you ask me to pay out of pocket the 3,000 euros for pacemakers, I won't be able to do that. So if two doctors cannot afford that readily, what do you say to the average woman who sells in the market? What can we do? Do these people just live like that and die without any cause when something can be done? So the main issues I'm going to look at are going to be the medical issues, the cultural issues, and the ethical issues. The medical issues, what's the major concern? Infection and device malfunction. If you look at several studies that have been done, and I particularly like what I've referenced there by Bayman et al., because it was a meta-analysis that looked at 18 studies spanning 1970 to 2010, and it involved 2,270 patients who had been implanted with previously used pacemakers. And what they found in their analysis was that the infection rate was about 1.97, essentially about 2%, which is quite comparable to the infection rates you get with new devices. And then with the malfunction rate, they had a rate of 0.68%, which is higher. But then, if you look at it, is it that high to the point that we say that this is a no-no area that we should go? The other concern is, how long are we going to have this device in? If you look at these issues, then we can make a case for it. And this is a slide that shows the studies that they looked at in their meta-analysis. The cultural issues, I mean, when Prof was talking about transplant, it's something that we always think about. In Ghana, we've been, for the past 4 or 5 years, we've been doing kidney transplant, but so far we've been using living donor transplant, and it's worked well. But I look at our people, I look at our worldview, and I wonder, are we ready for cadaveric transplant? So this becomes a good framework for us to look at this issue. There's the ordinary African, the way we view death. I always say that we love the death more than the living. I mean, in Ghana, the amount of money that is spent on funerals, it's amazing. I don't know about the other African countries represented here, but we really respect the dead. So are we going to be comfortable taking things from the dead and give it to the living, even though it can benefit them? What about, I mean, someone getting a pacemaker and being aware that this is from the dead? I'm working mental health. I've been there for the past 18 years. And even without any devices in my patients, I have quite a number of patients who come with certain beliefs. So I was just thinking, this person has a device and comes in and says, I had a dream and the donor was coming for it. It's a very realistic thing, at least in my area of practice, and I think I can boldly generalize that our worldview as Africans is something that may actually mitigate that. And then we also have this perception, which is very real, that Africa is the dumping ground of the West. So if this thing is not good enough, why is it being done here? And that's why I like the idea that Sweden was the first country, at least, to record this thing. And from 70s, they were doing it. I think the last one they did was in 1996, but because of litigation and things, they stopped. Because, yes, the device can malfunction, but if it is reused, you are more likely to get a lot of issues than if it is a new one. So this perception is real, but let's look at what is out there. Really, in the absence of not having anything at all, should the best be the enemy of the good? Yes, we want the best, but if we can't afford the best, can we look at the good? Ethical issues. Yes, we can, but must we? There are lots of things that we can do, but should we do them? Must we do them? If the medical evidence shows that this is a feasible thing, this is plausible, we are not going to cause harm, can we reflect on the ethical issues? And this is where my take is, because as a bioethicist, we want to make sure that whatever we do for our patients and humanity in general is ethical, is moral. We're going to make sure that what I require of you is something you require of me. To quote, Kant, the categorical imperative states that if I'm asking you to do this, then at the end of the day, you can also demand the same of me. So I'm not saying that you go and transplant an explanted pacemaker in Kofi and then you wouldn't want it done in Amma. So can we do that? Well, if you look at the basic ethical principles that we work by, we look at respect for autonomy or respect for persons, we look at beneficence, we look at non-malfeasance, we look at justice, others think about the common good, especially within the African concept where we're still largely communal. And then you can also look at the principle of stewardship. Are we really managing the resources that we have the way we should? We know from Prof's lecture that we are not doing great on that. But pacemaker donation promotes the well-being of recipients with no access to the therapy. So rather than to say that you're going to die of your bradycardia, you're not going to get anything because you can't afford this. If people are willing, and there's overwhelming support from pacemakers, people who have them and their families to support this initiative. So if people are willing to donate this, is it okay for you to do that? And I think it is, because it's going to be beneficial. The other issue is informed consent. Are the donors going to consent? Yes, if they can give advance directives, but if not, once they die, their relatives can do that. And then the recipient is also made aware of the source of the pacemaker. And then if we make sure that we sterilize it according to standard, then the harm is markedly reduced. So there's standardized sterilization, device is handled properly, it's well implanted. We have an oversight team to make sure that others, middlemen, don't get it and divert it so that those who really need it don't get it. And then we educate the patients and then follow them up. So in conclusion, based on the short time that I have and what I have said, I think that we can say that pacemaker reuse is safe and effective, and it's also been shown to be cost effective, even though there's a slightly increased risk of device malfunction compared to the use of a new pacemaker. The risk of infection is comparable to that of a new implant, and then for patients who really cannot afford a new implant, pacemaker reutilization is an ethically justifiable thing to do. Thank you.
Thank you, Doctor. We call now for the second presentation Dr. Jayan for the analysis of coronary artery surgery in Ghana.
Discussion and conclusion. It's more than a decade now that they started experimenting how to do revascularization surgery in humans. As of now, a lot of research has gone on, and today, since the surgery of Kolesov, a Russian surgeon who carried out the first implant of the mammary artery to the LAD through mini thoracotomy, he is considered as the first man who did CABG. And then René Favarolo, a year after, also considered as the one who popularized the surgery or the treatment for coronary artery bypass. Until then, most of the surgery were done with the heart beating. So the 1970 and 1975, the safety of perfusion technique was standardized, and the method of myocardial protection by means of cold cardioplegia were developed. As a result, most surgeons who were doing then off-pump surgery decided to abandon it and go on the conventional surgery. For financial reasons, others from a poor country, possibly in those days like else, decided that it's too expensive to be on the machine, so they went back to the beating heart surgery, Benetti from Argentina. Benetti also helped to do the mini thoracotomy, a surgery that lately we are all going to be trying to be part of it. Off-pump or on-pump continue to be the standard surgery for coronary artery disease in most countries. And from the records, Professor from Pomboatin did the first coronary artery surgery in Ghana in 1995. Looking at the evolution of the therapeutic option for coronary artery disease, it started by drugs. We moved to the conventional surgery. Now we have up-pump, mid-cap, the robotic surgery, angiogenesis, stem cell, and the PCI. So we have to follow the same trend. The thing is moving forward, but we are still at the conventional stage. So this is the technique of surgery. You are just bypassing an obstruction. You are bypassing this obstruction by connecting either an artery through the mammary or a saphenous vein bypass. So we did a retrospective analysis of all our cases. The indication for surgery or occlusion less than or more than 70% of the artery, and the source is from the folders and the theater logbook. Our results, 44 patients were included in this surgery with a mean age between 58 and plus minus 8 years. Actually, the youngest we operated was 45 and the oldest was 71. Male patient contributed majority. The risk factors for coronary artery disease, we all know them. In our case, hypertension and dyslipidemia were the commonest. We all did this surgery through stenotomy. By time, we can continue the video. And we did it with a conventional surgery, whereby we use a extracorporeal machine and cardioplegia solution to stop the heart so that it permits easy manipulation of the heart. It's a bloodless field, and it gives you adequate time for anastomosis. This is a picture of our set. Most of them will use the cardioplegia solution, Santoma solution. And our results are not far different. The mean ischemic time is 74 minutes. The total bypass time is 128. And believe me, if you're doing on-pump, most of the time, you add the reperfusion time. That most of the time is almost equal to the ischemic time. The corporate vessel that was actually is the LAD or the left anterior descending artery, and we did more than 2.5 bypasses per patient. The ICU stay was average 3 days, and the total stay in the hospital, actually post-op, not pre-op. Pre-op is not included. It's after the surgery was 13.6 days as an average. The medium-term survivor, that's of our cases, from 0 to 1 year, 12 months, was 93.2, and above 5 years, we have 63.6. Discussing this paper or talking about it is that if on-pump or operating the patient with cardioplegia and the machine is so fine, why is it that most people now are talking about off-pump? And I'm sure you will not be the only one thinking about that, because this question has been going on in heart surgery for some time. Off-pump versus on-pump. Which one is good? Which one is not good? And there are some studies that actually, I just quoted them. The Cochrane Heart Group actually did a research and said that the on-pump is good, has a better long-term survivor, and it should be considered a standard surgery for everybody. And off-pump should be only considered for those who cannot be cannulated. But the critics say that this study was done in a teaching hospital whereby they have a lot of trainees, meaning most of the off-pump were done by residents or young consultants who were in training. The coronary trial came out. This is a study done in the US, covers about 4,752 patients. And they divided the outcome in two, the primary endpoint and the secondary endpoint. The primary endpoint, they said that there was no difference in comparing death, MI, stroke, and renal failure, either going off pump or on pump. But when you talk about the secondary endpoints, that repeat revascularization, chest infection, acute kidney injury, blood transfusion, and reoperation, the off pump cases were better. So, conclusion. The limitation in providing reliable data concerning the incidence and treatment of coronary artery disease may be the reason why it's very rare, this surgery in Africa. Hypertension and dyslipidemia were the commonest risk factors associated with coronary artery disease. And despite the few numbers, our results is comparable to the results seen elsewhere. Thank you.
Thanks a lot. And now for the third communication, we call Abu Bakr for the excision of a giant anterior chest wall plexiform neurofibroma and chest wall reconstruction with methyl-methacrylate and vertical rectus abdominis musculateneous flap. A case report.
Now, primary or metastatic chest wall tumors usually infiltrate all the layers. At times, they may even extend into the chest cavity. Surgery poses a great challenge because you end up creating a large defect, which at the end of the day you have to reconstruct, and you also there's also cosmetic deformity. And before any resection, it's always important to plan the reconstructive possibilities. The aim is to present our experience. The patient is a 24-year-old farmer who presented us with an anterior chest wall mass with multiple truncal and skin nodules. Mass was painless and not associated with respiratory symptoms, and nodules were not associated with itching. No visual or hearing impairment, and no family history of similar problems. He had widespread subcutaneous nodules with widespread café-au-lait spot, with a chest wall mass measuring about 16 by 14 by 8 cm, hyperpigmented skin over it. It was firm to hard in consistency, and the breast sounds were vesicular. Chest X-ray revealed cortical destruction of the sternum, but there was no intrathoracic extension. Chest CT scan was not done. This is a photograph in the theater before surgery. He was anesthetized. He was given general anesthesia, placed in spine position, and we can see the chest wall mass with multiple skin nodules and café-au-lait spot. This is the mass exposed. Yeah, this is defect created after excision of the mass. Next, please. We use a sheet of paper to actually estimate the size and the shape of the defect so as to enable us mold our methyl-methacrylate for reconstruction. Now, this is methyl-methacrylate that we have molded outside. We now sandwich it in a Prolene mesh. Next slide. Now, the methyl-methacrylate was secured to the defect. Now, we sutured the Prolene mesh, that is the edges of the Prolene mesh, to the edges of the wound. We use vertical rectus abdominis muzzle flap to cover to provide a soft tissue cover, and that is the estimated size of the vertical rectus abdominis muzzle flap. Now, here we raise the flap. Next. And here we have advanced the flap to cover the defect. And this is the immediate post-op on the operation table. And this is the patient 1 month post-op. Now, plexiform neurofibromas are benign nerve sheath tumors, usually congenital, but may present during the first year of life. They are generally slow-growing and painless. Most are asymptomatic, and they have potential for a malignant transformation. Unfortunately, there is no effective medical treatment the only option is surgical resection, and the decision about surgical management must be made judiciously, and multidisciplinary approach is desirable in this type of situation. Like in our own patient, we operated in conjunction with plastic surgeons. After chest wall resection, skeletal reconstruction, when appropriate, and skin covering are essential elements. And reconstruction is important in order to maintain adequate ventilation. This is because you don't want to leave a flared segment which may eventually affect the ventilation of the patient. And you want to protect vital structures like the heart and great vessels. And you also want to maintain the cosmetic integrity. Now, these fellows were the first to report the use of sandwich technique, and since then it has been used worldwide. Now, Mansour et al. Reported their 25-year experience with the use of in chest wall reconstruction, and they concluded that it gives excellent physiologic and aesthetic outcome. That is when you use methyl methacrylate. Various flaps have been used in the reconstruction of the chest, defect, and the versatility of these flaps have been demonstrated by the authors shown above. Now, we manage our patient with plastic surgeons. We use rigid coverage because vital structures were exposed, and we use vertical rectus abdominis mycutaneous flap to provide soft tissue coverage. So in conclusion, we said that excision of chest wall tumors poses two challenges, cosmetic and also the defect that is usually created. The use of sandwich technique and soft tissue closure with mycutaneous flap overcome most of these challenges. Thank you very much.
The question I have of you is there not the other side of things, which is to start talking to the manufacturers to produce a device of equivalent cost, which may not have the same technical successes as one would exceed in first-time usage of devices, but you're talking about a device failure rate of 0.68%, which is outstanding, and I suspect that they can produce a device at about the same cost without then the risks of infection.
I'd like to congratulate Dr. Gian for his experience with coronary artery surgery in Ghana. I just want to find out what your mortality rate was for the patients, in-hospital mortality. I know you talked about survival over 5 years. For those 44 patients, it would be nice to know what mortality was. Did you have to do any emergency bypass? And did you do any surgeries on patients with left main critical disease?
Now, use of pacemakers is something we've all been thinking about. But I think to reuse them in an environment, we must have our own local statistics. You quoted an infection rate, which is in the Western world. What's the infection rate of regular pacemaker use in our environment? From my practice, I analyzed it recently. It's 5.4%, which is high compared to the Western world. I had a look at the experience from Senegal, published by FIA in 2003. They had an infection rate of also 5.4%. There are 5 patients out of a series of 92 that got infected. Now, interestingly, in that experience in Senegal, they had half the pacemakers were donated and recycled. So the question is, did their infection rate come from the recycled pacemakers? They might come from my local environment, we don't know. So we need, it's also an argument for robust databases. Analyze on experience, we know what we're doing. We then see, can we extrapolate this to other things like this that we use?
My question is on the presentation on the coronary artery bypass surgery. I just want to know whether in your cases you use for all cases you use the internal mammary artery, or you also use the saphenous vein graft, and if so, were there any significant differences in addition to the length of operation and your outcomes? We want to know because it wasn't specifically mentioned. Thank you.
First question is on coronary artery bypass. In the 44 patients you mentioned, I don't know whether we have had any case of redo that is secondary to restenosis. Another one is on the chest wall tumor. The incision that was done, I don't know whether it is R0, R1, R2, because the use of frozen section or not use of frozen section was already mentioned. And then was histology done post-op? And how is the patient being followed up? Thank you.
I want to know the method of sterilization of the explanted generator, or how you get to sterilize it if not adopted any method. And to Dr. Jan, to add what Dr. Pierre said, I want to know the mobilities associated with your TAD. Thank you.
You will agree with me that medicine is practiced within a cultural environment, and laws and rules elsewhere may not necessarily apply in our cultural settings. Do you think it's very necessary to let the patient know that you are giving them a pacemaker extracted from somebody who has passed away, and then further on going to tell the relations about extracting it from their dead relative? Thank you.
We used to be this in Ivory Coast. We started that more than 10 years ago. And just to say that your conclusion, I totally agree with that. There is no problem to know where you can assume. You used to speak to the people, the patient that the second kind pacemaker, and there is no problem. Thank you very much.
With the infection rate, I'll defer to any of the cardiac people. Dr. Jan is here, so maybe you can comment on that, or my husband can tell you the infection rate of the pacemakers. I'm not a surgeon, so I don't have that data. But I do know that with the sterilization, ETO is used. In fact, with the project that we are working on, we are going to look at the Swedish method that they use, because the longest data that is available is from Sweden. So I can give you the details of that with the full paper that we have. In terms of the manufacturing, I hope the Medtronics guys are here. Medtronics is huge in Africa. And there have been talks with some companies in India. In fact, I know that one of the, I think it's Vietnam or Philippines, they have an agreement with a manufacturing company in India. I don't know the name, but they are able to produce pacemakers at the cost of $800, and they are being used. But it is also known that people have this issue. If you say that we should produce something at a cheaper cost, is it going to be of the same quality? This brings us back to the issue that we have in Ghana, that yes, you can get the brand new, let me bring clothes, I'm a lady. I can go to the shop and get a brand new clothes for maybe $50 or $100. And I can also go to a good second-hand boutique and get a good second-hand thing for maybe $50. And I wear it, and you would appreciate the second-hand more than the new because of quality. So if we can't guarantee that they can manufacture the same thing at the same quality for a lower price, then let them do the regular one, and those who can afford, and those who can't can access it, because we don't want to compromise. You talked about the malfunction rate. So yes, if they can do something comparable and we are happy with that, I think it's a good idea. And companies like Medtronic and Boston Scientific can really take this up as social contributions. I think, yeah, I'm done with my questions. Thank you.
All right, thank you very much for the comments and questions. You asked about the histology. I forgot to mention in my presentation that we did a true cut biopsy, and it turned out to be a benign tumor. And even after excision, it was still a benign, so there was no need for a frozen section. Thank you.
I'll start by commenting on the procedure, like where if we use mammary artery for all our patients. Yes, it's a standard procedure. I'm sure no surgeon today will go to theater without harvesting the mammary if you are going to do cabbage. Unless there's a contraindication, you have to harvest the mammary, because that one gives you a guarantee more than 10 years. And the saphenous veins are going to give you a guarantee. After 5 years, you have to, because of the arterialization of the vein. So you will not go in there without using the mammary. All of them, the 44 has Lima to LAD, the mammary artery to LAD, and the saphenous vein as a graft to either the right coronary or the circumflex. But if you saw the image, because of time, the image, what we did was a sequential graph from mammary to one of the OMs. You use a vein to connect to the mammary artery, divert some of the flow, so that at least we can get almost a partial complete arterialization of our bypass. None of them were redo, actually, because there's one problem about doing analysis of data in our department. I'm sure it is the same elsewhere. It's follow-up information from your patient. So our mortality, the one who asked for mortality, how was our mortality of a patient, inpatient? Inpatient, actually, we lost only one diabetic patient. The diabetic patient was fine in the ICU, extubated, sitting down. The following morning, we were thinking of even discharge from the ICU. He just got cardiac arrest, and actually, we went for the PM. We couldn't get if it was a clot in the thing, nothing. We couldn't trace. So actually, there's another paper that is going to come out about diabetes and coronary surgery in our department. So I do not want to add that information to this. And the other person asked about the mobilities, complications. Complications of cabbage, we all know them. And the complications, at times we don't document them. The common complication we find in our patient was low cardiac output, which we were supposed to define, because most of our patients, when they go on bypass for a long time, because our ischemic time was 74 minutes, and the total bypass time is almost 120-something minutes. You know that most of the ischemic heart will go into low cardiac output syndrome. Is it a complication or is part of the procedure? Most of our patients were on atrophy support, so that complication was analyzed. But the very few one that we analyzed was infection of the wound, especially the limb ischemia. We got one patient with a diabetic who has infection of the leg, and unfortunately, when we probe into his infection, we got to know that he has peripheral vascular disease, and that ended up even in amputation. And that one will come out in the diabetic patient, because we try to exclude them in this analysis. Thank you.
So just a precision about the coronary artery bypass. For sure, in Africa, the epidemiology of patients who have coronaropathy is not clear, because there isn't a lot of cath lab. In Morocco, it was the case, and now with the development of cath lab, we have 30% of population who needs bypass, who are catheterized. So you have to, maybe when you begin a program of bypass, to begin the good program, well, to choose for the skeletization for the mammary artery, so you can not use saphenous vein. Use the two artery mammary, do egret bypass, and the alternative to choose the off-pump cabbage. It's a good alternative for Africa because the costs are really less. So when a unit choose to begin this program, maybe you have to choose the off-pump, but also if you choose the off-pump, you have to do cases, because the quality of the anastomosis depends on the number of cases we do. And also the two artery mammary and total arterial bypass. It's very important. So thank you for everybody for this session, and we do the second roundtable discussion.
Thank you very much, Prof. Shauni, and thank you to all the speakers.